The North East Essex Health and Wellbeing Alliance End of Life Board have created a data dashboard to drive forward improvements in end of life care across our community. How people die is important. How people die remains in the memory of those who live on. People we speak to tell us stories of how their loved ones were cared for at the end of life. It's important that we reflect on what is the priority for people as they're approaching the end of life and deliver care in line with their wishes. This should be the case whoever is caring for the person at the end of life, whether they are in a care home or the hospice, in hospital or at home. It is our job as an alliance to ensure the best possible care for the people that we serve. We asked our population in a consultation what was important to them at the end of life, and they gave us 10 priority outcomes that mattered to them. Our job as the Alliance End of Life Board is to ensure that as many people as possible get the best possible outcomes in the last year of life. To measure how we are achieving this at present, we have devised 10 indicators from those outcomes. For example, people told us that they wanted to know that they were approaching the end of life. They had plans they wanted to put in place, people they wanted to speak to, issues they wished to resolve. We know that we have in our area the My Care Choices Register, a register for people's preferences in later life and towards the end of life. We consider that if somebody has had somebody has been able to record their choices on My Care Choices Register, that they will have had a discussion about their priorities and preferences for end-of-life care. Therefore, we measure the percentage of people who manage to record their choices for sharing with healthcare providers as a percentage of people who die each year. Another example is that people that told us that they wanted good symptom control. We can measure how many people have prescribing put in place at the end of life to deal with any symptoms that occur. So we measure that as an indicator of how well we are doing at thinking ahead, considering people's symptom needs. So what is the purpose of the dashboard? The purpose of the dashboard is to demonstrate the outcomes that are already being achieved in end-of-life care in North East Essex. It is to encourage us to improve the way we work together to achieve better outcomes for more people. It helps us focus on areas of inequalities in end-of-life care, and it's a driver for change. Page dashboard. On it, you can see the record for each outcome and indicator. This front page of the dashboard shows us those indicators across our whole locality. For example, outcome 1 is that people wish to know they are approaching the end of life. So we measure that by recording what percentage of people have access to My Care Choices, with the hypothesis that if somebody has had a conversation about their end of life care wishes, that conversation included a discussion around their prognosis. We can see here that as a community, over half of our population have access to My Care Choices before they die. And 80% of those people have recorded a preferred place of care. We can see that over 70% of those people die in their preferred place of care. And we can see that overall, the percentage of people that die in hospital is falling. We know that people don't want to die in hospital. If you're on the My Care Choices register, the chance of dying in hospital is less, only 20%. People told us they wanted to avoid unnecessary admissions to hospital. And here we follow the data that tells us what percentage of people have repeated admissions in the last 90 days of life. There is still work for us to do. Our dashboard also tells us how we are performing equitably across the system. This slide shows us how the indicators are across different primary care networks, groups of GP practices working together. The ideal would be that if that a patient registered with any GP practice in North East Essex would have equal opportunities to have the best possible outcomes at the end of life. But we can see that that's not the case. These graphs follow, the yellow line here follows the locality average, and each grey line shows the achievement of each primary care network. Here we see one primary care network, and we can see that the people registered in those practices have good access, but perhaps less good access to anticipatory prescribing. This enables leaders in those organisations to drive forward improvements of end-of-life care. We also measure outcomes according to condition. So if we take the sample, we should see that people have access to My Care Choices that is the same whether they have heart disease, dementia, cancer or respiratory disease. But in fact, we find that that's inequitable. And we can see here that if you have cancer, you're more likely to be asked what your priorities are than if you have heart disease. We need to focus on this and rule out inequalities between people with different diagnoses. Historically, people from areas of deprivation have had poorer access to palliative and end-of-life care, and we can see in North East Essex that unfortunately we are no different. If we take the same example again of people with access to My Care Choices, we can see that people in the least deprived areas have the best access. And although access to My Care Choices has improved over the last year, there is a greater widening of the inequity, with people in higher social areas of less deprivation more likely to access advanced care planning than those who live in areas of deprivation. This is inequity that we need to resolve. We also know that people who are elderly, who live in care homes, are likely to be approaching the last years of life. We looked at the chance of people in care homes having access to My Care Choices. This graph shows us the percentage of people in some of the care homes in North East Essex that have access to My Care Choices, and we can see that this is unequal. We wish to resolve this inequity so that everybody who is approaching the end of life in a care home has access to My Care Choices, a chance to say what's important to them, and for care to be coordinated around those choices. So if we follow those outcomes through, we can see that our first outcome is that people are identified in the last year of life, and we measure that with our indicator that people are recording their choices on the My Care Choices register. This is our system-wide achievement against that. This is that data according to diagnosis. We need to resolve these inequities. This is the same data according to primary care network, which GP surgery somebody is registered in. We need to have fair access to some of these services across our whole locality. And this is access to My Care Choices by deprivation. It is unacceptable to have unequal access to services such as My Care Choices for people from different areas of deprivation. If we follow a second example, people said they wanted to have good symptom control. So as an indicator for this, we record who has access to anticipatory prescribing as it's recorded on My Care Choices. This is medication put in place ahead of time to control symptoms at the end of life so people are comfortable. We can see at the moment that over 42% of people have that recorded on the register. But that is unequally spread. You are more likely to receive anticipatory prescribing if you have cancer than if you have heart disease. And yet we know that symptom burden is similar. It is unacceptable to have this inequality, and we need to resolve this. We can see that access to anticipatory prescribing depends on which GP surgery you're registered with. It should be the same level of access, but we can see that it differs between primary care network. We need to resolve these inequalities. The access to prescribing for symptom control at end of life should be equal between different levels of deprivation. And we can see here a positive sign that access is improving, and also that the inequity between the different levels of deprivation is decreasing. This is positive, and we need to continue to work to address this issue. In the future, we hope to be able to incorporate ethnicity data into the dashboard, examining any inequalities in end-of-life care for people with from different ethnic groups. We're working to include patient feedback data into our dashboard so people can tell us whether they're being treated with dignity, whether their symptoms are controlled in more detail, whether the conversations they're having are compassionate, and whether their carers are supported. And we'll also be looking in more detail at our financial data, how we are spending the resources that we have, and for the outcomes that people are prioritising. In summary, this dashboard will enable us to scrutinise how we are working together as a system, to focus on areas of inequality, to measure how we are doing against each outcome, and to create change that will improve the end-of-life care experience for our population. Thank you.